Yeah. You know,
Yeah.
mate, tell us what you had.
40-year-old traumatic cardiac arrest, pedestrian versus car.
Yep. Cool. And what went well for you, mate?
So I think initially it was resource poor, so just trying to work out what the pattern of injury was to treat that first, to identify where on the priority of reversible causes I slot that into my algorithm to try correct that first and then move on in a sequential fashion to make sure nothing gets missed.
Yep.
But I just found it probably initially clunky as a single officer initially.
I don't think anyone wouldn't find it clunky. Yeah. It's designed that way for the reason. You know, you so many competing priorities and your resource management just has to be so tight just to keep that forward momentum in these ones. So I think that's exactly what it's designed for. Put you under the pump and see how you can manage multiple things in a sequential order with prioritization. So it's good, mate.
Yeah.
Would you do anything differently next time? Have you identified anything?
Probably just a bit quicker with the procedures. It just felt a little slow initially.
Sure.
But I think once I extricated him, it was obvious that it was predominantly potentially head chest. So priorities come around establishing an airway and decompressing the chest to release any tension physiology. And then probably, as a further concern is also, the high back tension. You've got to be thinking internal bleeding potentially causing that. But so initially my sort of plan was establish an airway, decompress that chest, and then for that internal hemorrhage, that all I can do is sort of try correct that by using IV fluids to get some form of circulating volume around.
So what were like your primary injuries?
Head and chest.
Head and chest, yeah. Any one more than the other, or?
Probably the chest was the main cause of the hypotension.
Okay,
I would say that he's got some significant chest trauma, worse on the right, which required sequential further decompression on that side. So.
And when you say head, what's your thought process there?
So traumatic brain injury, but he could also, probably, I'd say impact brain apnea probably playing a fair part in it.
What was your evidence of a head injury that you...
Well, his head was under the car initially,
and
we reported some occipital
there was hematoma.
Sure.
So that was the head injury side of it, and then the chest side of it was the paradoxical movement with reduced air entry, worsening SATs, worsening hypotension.
I think the mechanism, I think like the weight of this vehicle is laid on his chest, plus or minus maybe a little bit of head involvement. Primarily I think whatever structure his thorax has been on under there has been like pinned down and crushed. And whether he's had a period of sort of hypoxia, but we also know we've got this underlying thoracic pathology too. He's got obviously there'll be vessel damage there. We've got pleural damage there. Like we've got we know we have these significant flail segments there. So we've got all those things going on there. Mate, overall, I think you really nailed it. I was pretty happy with everything you did there. Great order, great immediate action onto the needle decompression on the chest very early. Algorithms, you maintain tight control on that. Good role delineation with both your offsiders here, and you actively went through your list of like reversible causes, just to ensure that you were addressing each one of them that you could. So I was really happy with all that. Great index of suspicion for the primary being the chest, and plus or minus that potential head there. Couple like points of consideration there. I know we got to the TXA at the end, which is totally fine. I think it's good that you considered it.
I think it's probably an on the way thing potentially.
Yeah, potentially. I mean, we've got ROSC, so the priority as soon as you've got ROSC, providing we maintain ROSC, is expedited transport out of there. Off to which is you're at the Wellmore, requiring a unit for that. I guess in case you had an ambulance there, you'd be prioritising moving.
That's what I thought. Stretcher move and then set up.
I know that we're playing around at the end with a little bit of, like we've got
Yeah.
a little bit of lacrimation here, so I think it's analgesics, but I think it's fantastic, considerations. But think about forward momentum there, getting out there. Do you think maybe alternate sites for the needle decompression?
Yeah, well, you could go in the anterior midclavicular line, slightly anterior to the midclavicular line there. I think if you get feedback though, like we did on the second one, I'm more inclined to just probably keep going in the primary recommended site.
Okay.
But yeah, I think especially with the ones that we use, that I think that the problem is that it's all right for a digital thoracostomy, but when you've got the arm movement sort of,
with the needle hanging
potentially, pushing down on the needle with the potential for, further iatrogenic injury to the underlying lung structure. But I definitely think that it is a worthy, alternate site. But I think, in my mind, I think you'd probably have to transport them.
You would be good. I mean, I guess with the ones we use, it hangs out.
You'd have to. I think you'd have to move the arm, situate the arm.
Oh yeah, I'll probably just hang it up. Because I mean, like, they're not the Teflon ones where you feed them off.
Yeah.
So it's taking up a bit of space. It's just, I think it's good just to have a consideration of how many more times am I going to have to go interior if we read tensions before I try something different. Particularly if it's got that pneumothorax, we can get air out of the top, but maybe by reducing our angle, going down a little bit lower, we might be able to get some blood out, maybe. But that's neither here nor there. It's just a good consideration. You're pretty quick with it all, like overall about 20 minutes, which is good. Look, what's the priorities this patient needs from there?
Oh, they need blood. RSI. For neuroprotection. And code 1 transport.
And a finger to the chest. Which I think, depending on the setting, if you're 30 minutes away from a regional centre, then that's what the information they're giving us. You're probably just going to go there, get those interventions, and then, be evac from there. Happy with that? Anything you'd like to add in?
Really well done, I think. From a second officer point of view, it was calm, clear instruction. I had a clear picture of what you thought the diagnosis was and what the treatment regime was. So, well done.
Because the only other thing I was thinking is, I'm not a big fan of pushing the adrenaline on those, clapped out hypotensive trauma patients where they're bleeding, but I suppose trying to figure out where's your line in the sand.
I think when you look at the reversibles, like the hypoxia and the obstructive pathology there, with the tension, I don't think really adrenaline would give us any purchase, and it might actually push us back. If we've got massive subclavian injuries and whatnot, you probably.
I think it could just potentially worsen bleeding.
I think it's been. They talk about in hypovolemic shock. That it doesn't really have a role with the in the trauma. But also, if we're concerned about instrumenting the airways for an ETT without paralytics and anaesthetic on board, because of a possible transient spike worsening traumatic brain injury, then but then we go and push adrenaline. That. I think we've got to worry about if we're worried about a head, what's the adrenaline going to do? It might get big spikes. The blood pressure was pretty good.
We're sitting at 90.
And it always was in correlation to the chest. The chest was playing up again, blood pressure went down. Address the chest, blood pressure went back up. So you can still see what the trend is there. It's very reliant on what's going on in the chest.
It needed, like you said, it needed a finger thoracostomy.
Absolutely, without a doubt. As the bystander, any feedback?
No. Thought you did a great job.
Cool.
Yep.
Oh, no.